Good morning, good afternoon, or good evening, depending on where you're joining us from. My name is Jason Buffington from Veeam. This week, I am delighted to have as my guest one of my colleagues, Jonathan Butz. Good morning.
Hey, good morning, everybody.
So I am from the great state of Texas, but as I look on our map, because we are actually curious as to where are you coming from and joining us this morning, I'm looking on the map, and already South Africa has already signed up for the list. And as I have said, every time I see South Africa chime in on this, they have arguably the best meat for anyone who doesn't come from the state of Texas. Perhaps the only meat dish that neither Texas nor South Africa has mastered is the great Philly cheesesteak, which of course my good friend Jonathan from Philly, right? Ish.
Yep.
So we do have all the carnivores represented, but please tell us where you are from on the map as we go on. All right. So introductions aside, typically when we on the live stream we talk about data protection and trends, we often do it from a general purpose, like all industries are created equal. Turns out not all industries are created equal, and one of the industries which has always been really, really dependent on data, creates a lot of data, the availability or lack of availability of data really is critically impactful, is healthcare. That happens to be an area that the other person with the initials JB happens to have some experience on. Jonathan, give us a little bit of your background first so that we know that you know what you're talking about, and then let's talk about healthcare.
Sure. So I'm Jonathan Butz. I run the healthcare practice here at Veeam. I joined Veeam in June of 2018. So I've been here just over 2 years. And before joining Veeam, I was a part-time CTO for several hospitals, both in the Philadelphia area and on the West Coast. And before that, I was part of VMware's healthcare strategy group as a healthcare strategist and product manager at VMware.
Fantastic. So you've been watching the healthcare market for a very, very long time. There's never been a time in healthcare that they weren't dependent on IT, that they weren't dependent on their data. But certainly this has not been a typical year for IT or the rest of the planet. I'm curious, as much as healthcare has always been dependent on their data, healthcare professionals have been kind of busy since last February. Can you talk about how the industry has kind of, both barrels kind of went after healthcare this year between IT and COVID? Talk about that flux for a minute.
So certainly healthcare, as you mentioned, healthcare has a tremendous dependency on IT under any circumstances. This year, of course, with March, we had a number of different scenarios unfolding depending on where the healthcare systems were located. In New York Metro, they were saturated almost immediately and dealing with the stress of a saturated health system. And then other hospitals in other areas were dealing with the fact that they had to shut down and curtail a number of important services. Anything not considered critical was furloughed until some future date. And those are revenue streams upon which healthcare systems rely for their continued operations. So we had health systems either dealing with a crisis, preparing for a crisis, or dealing with the revenue shortfalls of the crisis itself. Combine that with other dynamics that emerged at exactly the same time, shutting down on-premises operations and sending people home, getting new equipment out to all of those new people whose work-life environments completely changed overnight, and then implementing new telehealth services as quickly as possible. It was definitely a dynamic couple of months in March and April for our health system as a whole in North America. And I think, frankly, we saw modernization at a pace that we have not seen before, I think, in healthcare. Never in 60 days was healthcare able to demonstrate their agility so spectacularly. And I think we should be very proud of all of our peers who work in healthcare IT and their ability to have done that.
So let's talk a little bit more about the fallout and how that modernization might have affected the overall IT landscape of healthcare. And I think you've got a slide that has a few key statistics on that as well. So if the producer can bring that up. So it's interesting that so the top of the slide talks about loss and challenges from fiscals going down. Meanwhile, the healthcare industry perhaps has never been as busy both serving patients, and then, as you mentioned before, we've seen unprecedented amount of IT modernization in order to meet the changing landscape of what kinds of applications and data do have the users been expecting in order to meet these new service provider goals. Can you walk us through some of these, both where the losses really come from, and then let's dig into that modernization for a minute before we move on?
Yeah, so the losses, the bulk of the losses really come from having had to furlough so many non-essential services, and much of that is ongoing. We thought perhaps that would only last a brief period over the summer, but a lot of that has persisted even into the present, and with little end in sight. And then, of course, it's a rather devastating and precarious situation that we've put our health providers in right now, because in the midst of a health crisis, which we are not crawling our way out of. If you look at some of the curves related to COVID-19, they're linear. They haven't changed a bit. If you look at the nation as a whole, certainly some areas are doing better than others. But what that means is there is a continued need to optimize across the board. And of course, over the summer, we talked about other industries being affected as well. And of course they were. The IT capital supply chain upon which healthcare has long relied for expansion in terms of new gear, et cetera, was disrupted as well. And that had them looking at alternatives to on-premises capital expansion, oftentimes leveraging cloud infrastructure as a service, and especially software as a service solutions, which they could implement rather rapidly without waiting on those other affected things.
Yeah, Dave Russell and I talked about this just a couple of weeks ago. We were talking about how has the pandemic shifted IT, not only from a modernization pace, but also the kinds of levers they have available to modernize. So as an example, we talked about a few weeks ago was, any IT modernization or digital transformation effort that started with go get new gear and rack and stack it, those are non-starters. Right. Gear is not arriving at the manufacturing floor. And oh, by the way, the accounting person never paid for it because they've been working from home. And the IT person isn't coming in to go and rack and stack anything, and hasn't been for the last couple of months. Meanwhile, any IT modernization issue that was already in plan to say, hey, we're going to start using more cloud someday. Well, someday became yesterday for most of those organizations. And all of a sudden, SaaS starts becoming a significantly larger part of strategy. Before we dig into how SaaS is affecting within healthcare, let's go back to the map for a second. We want to see where folks are joining us from. So I already gave shouts out to South Africa, easily one of my most favorite places to visit outside the US. Senegal is in the house. Munich, Germany, always good to hear from. India, Boston. There's a few healthcare companies in Boston, as I recall. Guatemala, Romania, Miami, Mexico, Belarus, Israel, the Netherlands, UK is in the house. Cameroon. I don't think I've ever had a dial-in from Cameroon. That's awesome. San Francisco Bay. It's a little early for y'all, so thank you for joining. And then Italy. Truly one of the great places of art on this planet. All right, so thank you all, and please keep piling on, and not only telling us where you're from, but healthcare is a global initiative, obviously, and the pandemic has hit different places at different rates. We'd love to hear your questions about, or your observations on healthcare and IT and how this rapid pace of modernization has affected that particular industry. But let's go back to, we talked about how cloud is certainly a big part of that. The poster child for enabling remote workers has to be Office 365, right? So last week was Microsoft Ignite, or 2 weeks ago. Satya talked about all the ways that not only Exchange Online, but SharePoint and OneDrive and Teams were really, for many organizations, that saving grace that kept folks working together. Talk about, how does Office 365 and other notable SaaS platforms, how does that figure into healthcare before? And then where is that going from a modernization perspective?
So we saw actually pretty healthy adoption of software as a service in a number of categories pre-COVID-19. And Office 365 was easily the most popular for reasons that surprise no one. Microsoft has really demonstrated some prowess in operating that platform. The number of issues in recent years can really be counted on very few fingers, and it's a smart choice for any hospital to make. But they're not alone. There lots of people have been long doing Cerner as a service, hosted out of Kansas City and soon to be hosted other places. We see the rise of Workday for workforce management and financials, and also ServiceNow, very popular for Service Desk, all delivered as a service back to the organizations. And with the big pivot and shift to work from home within the Office 365 platform, we've seen the rise of Teams now as a collaboration platform among hospital support workers, being used extensively. And that, of course, has generated some new discussion and some new interest in the nature of software as a service data stewardship, and responsibilities for recovery. And that gets us into a whole new area of discussion that, of course, is, I think, much bigger than just Office 365, and gets into the details of where does our data live, who has control over it, and who has responsibilities to make sure that it can be recovered should the unfortunate befall whatever platform it runs on.
Those last three nuggets, Jonathan, are, to me, the perfect examples of what I would call short question, long answer.
Yeah,
right? There's a lot of complexities to deal with that. In the Microsoft Ignite keynote that Satya gave, one of the examples that he gave that actually saved a business was Teams, right? You mentioned Teams a lot in that that they went from Teams just being the how you doing and when you coming in to truly how did they service clients. Right, their entire business model changed from that perspective, and I think you've been watching the advent of what do we call it, telehealth, but the idea of how do we distributedly and remotely serve someone that's not physically in contact with along that way, truly changes the paradigm for what kind of data is going through that model.
It certainly does. It certainly does. And telehealth is not new as a concept or even as a capability. There were some barriers to its consumption in terms of what Medicare and Medicaid would reimburse, and other private insurance as well. In March, we saw that evolve. We saw some changes in the regulations that would allow to bill for the first time, and the shedding of copay for remote visits as a further incentive. There's actually discussion now about whether to reinstate that, which is, I think, very interesting. But Teams, and so for clinicians, we have different software solutions for different purposes. Clinicians rely on electronic medical record systems and other clinical systems to do their work. Office 365 is often not a significant portion of their daily experience. But for all of the support personnel in finance and in operations and in IT and in all of the other support offices necessary to make a hospital and a health system actually work, they have become very reliant on Teams for collaboration starting back in March.
Yeah, I mean, I just think about how many people do I interface with, even at just going to a general practitioner for a general checkup, from the person who's scheduling, the person who's billing, before I actually finally see someone who's actually a health professional along that way. Keeping all of those folks connected, both for the interpersonal experience with the patient as well as organizationally within their own teams, pun in lowercase t, seems like it would be a huge area. It's fortuitous then, as we talk about, for many organizations, when they look at, say, Office 365, it wasn't that many years ago that when people heard Office 365, what they actually heard in their brain was Exchange, right? They just heard email. And if all you backed up was email, that was pretty good, because it's probably still better than what you're backing up in Exchange on-prem. And then over the last couple of years, what we found is now there's some backup folks that all they pretty much do is Exchange. Now, we have always been on that forefront of protecting not only Exchange, but also SharePoint and also OneDrive for Business for unstructured file data. We are super excited about the fact that in Veeam backup for Office 365 version 5, we actually have Teams support coming. And while not all the APIs are there yet to get that complete whole experience, man, we're catching just about everything. And as that architecture continues to evolve, we're going to continue to wrap our arms around more and more of that entire Office 365 comprehensive suite. So super excited that's coming out. Seems like it's good timing.
It's really good timing, because the one of the things that I think has been interesting in this transition to software as a service, we have not yet become we have not yet added some what I think are essential questions to our evaluation of software as a service vendors. And that is, where does the data reside? And can I, myself, as the owner of that data, extract a copy of it to preserve in case the unfortunate befalls a software as a service vendor? So, in the case of all of these software as a service solutions that we consume, there are contractual remedies for outages and things like that. And there likely are contractual remedies for data loss as well, but being reimbursed for data that was lost does not help you resume operations if that data is critical. And that really, I think we as IT professionals should begin to ask new questions when we're evaluating software as a service vendors. That is, do you provide me a mechanism to back up that data that is mine should the unfortunate befall you and your service offering? Despite all operational elements in place to prevent such a thing, the last defense against all things that can go wrong is a good copy of your data somewhere safe.
Yeah, let's be really clear on this one. This is one that I've actually been pounding on for a very, very long time. Whatever regulations, whatever operational mandates that you have for retaining data, whether it's previous versions, whether it's long-term retention, whether it's an assurance of availability, all of those operational mandates, that's just what responsible IT people do, and all those regulatory mandates, this is what organizations, either healthcare as an industry or government for the various countries would mandate. But either way, just because you chose to deliver IT as through a service as opposed to on servers does not absolve you of any of those requirements, right? So all of those mandates still hold across that gamut. I want to go into those regulations a little bit more and talk about things that still apply, even if you're using a service as opposed to a server. But first, we got a question from Jim. Can you touch on the impact of COVID-19 on HIPAA compliance? Ooh, this is going to cue right up into our regulation conversation with regards to providers and payouts exchanging data. Let's talk about that. Well, actually, do you want to go and talk about the regulations themselves first and then address Jim's question in context? Does that make sense?
Do that.
So I think you got a slide on PHI regulations. Let's go ahead and bring that up and talk about the regulations that actually apply. Let's get to Jim's question. Then I want to go back and see how the map is filling in.
So this is a fascinating topic. In every industry, there are regulations that drive the retention of different kinds of data. We have that in the insurance industry. We have it in the healthcare provider industry as well. And we talk a lot about data protection architecture. How long are you keeping your backups? And there's a dramatic range of answers. And a lot of times the justification that's given for keeping backups a long period of time is HIPAA compliance. And as it turns out, HIPAA doesn't have a whole lot to say on health information retention and nothing to say on backup retention. HIPAA is mostly concerned with the proper handling of sensitive patient health information. Who has access to it? What must they do with it? What must they not do with it? And rules for disclosure of breaches. Those are the kinds of things that you find in the HIPAA. With regard to data protection and specifics for IT, it doesn't actually drive a whole lot. It doesn't have a whole lot to say. It only says that we must have the ability, we must have best efforts to ensure that the data integrity is maintained, to reduce our risk, and we must have an ability to recover our lost data, and we should test those procedures. Not that we must, we should test them. Of course, any good operator knows that you must. It's actually when we get into the state regulations that we see the actual timelines specified. So if we look here, I have California here as an example. Patient records shall be preserved for a minimum of 7 years following discharge of the patient, except for unemancipated minors, in which case we must keep it 1 year after they turn 18, in any case not less than 7 years. Now you'll find some variation state to state, but there's a lot of similarity in terms of both timeframes and the general wording. The purpose of regulations with regard to PHI is to ensure safe handling of that information, proper confidentiality, and to make sure that following an encounter with a physician, there's a record of that meeting for a suitable length of time that could be used for some need after the fact, either referral or transmission to a new doctor or some sort of litigation.
It's always interesting to me. I've watched regulations happen across every major industry. Being in data protection for the last 30 years, I've watched quite a few of these regs come into play. what I always found interesting is that in most cases the regulations are not something which are meant to be egregious or just imaginative. They really are just trying to enforce something, if you thought about it, really is pretty much common sense, right? You ought to keep copies of data for how things happen in case you have to go back to them. In the case of whether it's not just patient records and engagement, but what about the trials that developed for bio on creating a drugs? You need to know how those tests manifested over time. If there's a variance later, we have to be able to go back. That most of it is operationally responsible. Problem is, not everybody is operationally responsible, and therefore now we have to put in a rule that says you have to. Is that fair for healthcare?
I think for the most part, healthcare has been responsible for quite some time managing records. Even if we look back to the paper file days, I mean, obviously paper charts were not ideal, but most health systems were relatively diligent about maintaining a good record of patient encounters for use after the fact. And now most of that responsibility, I would argue all of that responsibility, is now in the hands of electronic medical record systems and other clinical information systems that keep track of the details of that encounter, and they keep track of how that record evolves over time. They keep track of who looked at it, who updated it, who made comments after the fact. And this is true not only for patient encounters, but also, of course, medical imaging for the review of the images themselves. All that stuff,
Sure.
all of the work that gets done in healthcare is captured in some clinical information system. And those are the records to which the regulations truly apply. So this is where we should draw an important distinction between these regulations that apply to the medical records themselves and how we should then define our policies with regard to data protection and backup of those systems to which the regulations apply.
And also be really clear that when we talk about, so HIPAA is not the only regulation that applies. We talk about HIPAA as a global or as a federal standard. And then, of course, you mentioned that each state often has their own compliance regulations. And those records, as you mentioned, are predominantly for the patient-centric records themselves. But if you are a large hospital network, you're not only bound to HIPAA. If you're a publicly traded company, you're also bound to SOX, right? Yes. You are as the rest of your business, your accounting, your operations, your HR, those all have regulatory mandates too that have not only potentially an industry lens, also a federal lens, and very more than likely a state lens on managing that data as well, even if it's not healthcare specific. It's going to have different regulations for different kinds of data along the way. One thing that you mentioned as well that I'm surprised how few people do this. When you actually read the regulations, the good news is, well, I don't know if it's good or bad news, but the regulations actually don't tell you the how. They often will prescribe an outcome. You should hold data this long. You should have in some of the federal regulations, you should have data that's this far geographically apart because they've had outages that were shorter than that, so you have to protect against that. But they don't really tell you how, right? And on paper records, you had very few options, right? Make a big copy, stick them in a box, put them in a warehouse, good luck, right? In electronics, we actually have a much wider variety. Talk about, you and I have had side conversations on how health organizations sometimes will choose the technologies that they use, dedupe, disk, cloud, et cetera. Talk about that.
So what this is where I think this is where reading of the regulations and understanding exactly to what they apply is really important. So if we read the regulations that tell us how long we must retain our patient health information, and we agree that as many large health systems and hospitals do, that applies to the records that live in the information systems themselves. If we agree on that, then we will make very different policy choices about how long we're going to keep our backups, and that in turn will have a dramatic impact on the technologies that we choose. So so let's walk this through. Let's say we're a health system. We agree that the regulations apply to the records themselves in the clinical information systems, and then we define the purpose of backup as system recovery to the most recent known good state. And that's most common among the hospitals that I think are making the best choices with regard to data protection. Then then we want our backup infrastructure to be as lean as possible. And we see many hospitals, I've talked to many hospitals and insurance payers as well, who only keep their backups for 30 days. They recognize that for their organization, they have defined backup as the means to restore to a less known good. Now, I'm not saying that's one size fits all or that's the better for everyone, but there are many who have made that choice, and it's very lean. Now, we've had internal conversations that there are good arguments to be made for a little longer, maybe 60 and even up to 90. But I think what we do see, so let's talk about the implications though of the shorter backup term and what that drives you to. When you define your backup retention as a relatively short window, something between 30 and 90 days, you will invariably, for financial reasons, choose, if you're truly lowering your total cost, you will generally choose server-based repositories that are full of spinning disk. So you get very, very cost-effective, very deep storage appliances. And that gives you lots of vendors to choose from, so you really can minimize your total cost of that capital to use for data protection. The other benefit that comes along with that architecture in particular that I think is very important, that's oft overlooked, that infrastructure is also optimized for random reads, which is exactly what you need when you are doing large-scale restores. Doing a restore of a single system, we'll get decent data throughput or something small out of it for a single system, no problem, whatever backup solution we choose. But if we end up with a larger issue and we have to recover systems en masse, we're really going to be grateful that we went with that server-based repository that gives us all of that raw performance to do that massive system recovery as quickly as possible, which is, of course, what we actually need from our data protection infrastructure. And what we see is if we interpret those regulations to also apply to backups of the records, and we start desiring to keep our backups for years, and we could have a long discussion about why that isn't a good way to spend your capital, we invariably end up preferring dedupe appliances because they are optimized to store data, particularly the same data over and over again, for long periods. But because they're optimized for long-term data retention, they are not optimized for random I/O. And we may find that if that's the platform that we've chosen to retain our backups long-term, we may find that when we're in a situation where we're really relying on data protection to do a mass level restore, we don't have the performance we need to do it in the time frame that our organization really wants from us. So in my reading of this and in talking to lots of different hospitals about this over the last 2 years, the hospitals that are in the best position to do recovery as quickly as possible are the hospitals who have chosen a very short-term retention for their backups, just because of the technology choices that has driven.
Yeah, the thing that I hope folks hear about is, certainly, and let's put our Veeam hat on for just a second. We deliver capabilities across all of these, right? So if you're looking predominantly for rapid recovery at scale, an on-prem disk repository that is not deduped is your ideal scenario. For that mid-range data, certainly, we plug into all the dedupe appliances. You got some great experiences that come out of that. And I would do that, up to maybe 3 to 6 months. If you have data that has operational value that you want to mine, then all of a sudden object storage starts to become an interesting cloud-based option for repositories. If you have data that you want to hold for 10 years or more, I'm still a big fan of tape, right? So for all those scenarios, there is something that kind of holds true for that. Just a couple things I want to point out. So Barnadu actually had some feedback on, as we were talking about how the regulations apply. By the way, because the regulations don't tell us which formats of disks and tapes and clouds to use, right? And he cited the GDPR from not only from UK, from EU. One of the benefits of GDPR is that GDPR, among other things, looked at all of the industry-specific regulations, like those in healthcare, around the world and said, look, there's some common practices. And in fact, GDPR is arguably one of the more comprehensive ones. It just says, if you follow GDPR, you probably also follow most of the vertical or industry-specific regulations as well. So hats off on that piece as well. I want to go ahead and just give a last shout out and a thanks to some of the countries that just recently joined. New York, Toronto. New York is not a country, but they sometimes act that way in a good way. Toronto, Egypt, Slovakia, Tampa, Florida's in the house. Brazil, another good set of carnivores down there. Kenya, Lima, and Peru. So thank you all for joining. We got more green on the map this Monday than normal. So thank you for that. All right. So, Jonathan, give me a last quick word on actually before your final thought. Let me do this. We want to make a plug for on Friday. So this Friday, I think it's October 9th at 11 o'clock East Coast. We're going to be continuing our series around AWS protection. So Sam Nichols and David Hill, this is part 2 of 3 around Veeam and AWS protection. But Jonathan, I want to give you the last word on if you were talking to CIOs in the healthcare industry with everything else that's going on around data protection, what's that one thing you need them all to hear?
I think the one thing we need everybody to hear is it's never too late to review your data protection practices and architecture to ensure that you can recover according to what the organization demands of you. It's so often overlooked, and it needs to be reviewed just as any other critical data center function does.
And then just to sign off, in talking about healthcare, I'd be remiss not to say to all the healthcare professionals out there that have been serving so diligently for the last 8 months during this crisis, thank you for all that you do. And for everyone watching, thanks for joining us this week. Have a great day.